Thanks, James. Good afternoon, everyone. It's great to be here, great to share a platform with such a great group of people, and also to have lived experience on the call as well, and contributing is great to see. Thanks to Etta for her kind words earlier on. She may or may not remember that I visited her clinic over the years, going back many years. I visited her at Soho. I remember going to Fulham. I remember going to Earl's Court as I built up my knowledge and was looking for cash for the North, for the NHS to deliver gambling treatment. So I'm indebted to her, not just in the past over those years, but over the last 2 or 3 years where we've worked so closely together. And we've achieved a lot, and we've still got more ahead of us, working together with a whole variety of colleagues that she mentioned as well. So whilst the context is the expansion of the NHS clinics, there's no substitute for effective laws, effective regulation and evidence-based prevention activities. We can't treat our way out of the gambling harm that we're seeing across society, but clearly there are people that need us. But I just thought I would always sit any conversations about treatment in the context of a comprehensive public health framework that's needed, and effective laws in this space. So this talk, I'm coming at it from a clinical perspective, with a few observations that I've noticed, and just where the new clinics might sit within a wider system of care. The main call really here is that the clinics shouldn't sit in isolation, and can't sit in isolation for many important reasons. So a bit of context here that just before we go to this slide, we've got an OHID group. So this is, as James was saying at the beginning, this is the new Public Health England body. There's a group looking at treatment pathways that will provide interim guidance by the end of this year that will support the work of the NHS and the NHS clinics. There's also the NICE guidelines that just got underway. That'll be about a 2-year process, which again will not just focus on evidence-based treatment, as Etta rightly said, but also it will also provide guidance on an evidence-based system of care for gamblers as well, which is really important. There's also a consultation underway by the National Gambling Treatment System on treatment pathways as well. So anything I've got to say about that here is really just to start the conversation, and it will all be usurped by those by all those guidelines. Important to say that gamblers are not a homogenous group. It's one of the most important things to learn about this population. So whenever you hear about one approach or one thing working, we really need to appreciate that this is a very diverse population with diverse needs, and we need a system to accommodate that truth. So I think we need what's termed an all harms approach to gambling, the accurate identification of gambling related harm on a continuum of harm basis, and to embed this group into a wider system of integrated care. So next slide, please, Nez. In terms of identification, we've got a real problem on our hand, but reframing that, a great opportunity now with the clinics to have our partners and our national colleagues support us to identify gambling harm. Only 2 to 3% of those who are seriously harmed by gambling come forward for support. Nearly all of those are self-referrals, indicating that gambling is not embedded into the areas where we could be identifying these problems. Nationally, we're not very good at identifying and intervening early. Usually people are coming in very desperate straits. They've tried repeatedly to get the better of their problems. themselves, usually by the time it comes to coming for support. So we need to better identify and have earlier intervention built into the system, and obviously alcohol is quite a good model to develop from. It's also worth noting, not unlike other addictions, but gamblers often feel embarrassed and ashamed, and stigma really pervades this space and is a real barrier for people to come forward. So again, nationally, we need to do something about this. We're improving the way in which we think about mental health, and it's becoming, you know, much more normalized to talk about our distress and come forward if we need help. I think we're still quite a way when it comes to problems that are related to addiction and these sorts of behaviours. And the framing of that the industry have around personal responsibility probably doesn't help with that endeavour. So gamblers are likely to use some of the services that are on the screen there for related problems, but not necessarily, in a sense, putting their hand up to say, I've got a problem with gambling. So it's really important for our partners and colleagues across the health and social care ecosystem and the charitable sector to help by asking questions about gambling, as they would routinely, perhaps for smoking and alcohol and drugs. Gambling has a particular way of remaining secretive and hidden. It's quite difficult to hide an alcohol or a drug problem. It's extraordinary the lengths that some gamblers can go to in order to keep their gambling problem hidden. So it's incumbent on all of us to ask these questions and make them part of routine practice. And I think perhaps, you know, an example is primary care, and there was an excellent talk from Claire earlier on. Not necessarily going to go to their GP, although some do, asking for help related to gambling, but other problems may sit behind the gambling problem. So we need to be curious in our work and also make sure we have these questions that we're asking routinely at assessment. The other thing as well, I'm sure Jim will say more about this later, is we also need to ask if they're affected by somebody else's gambling problem. The effect on loved ones, family members, colleagues can be very, very significant. Okay, next slide, please, Naz. So from a clinical perspective, the population have some needs that these clinics can't meet and won't be able to meet. So it's important that the long-term plan transformation ambition of the gambling treatment clinics are played into conversations about integrated care systems. The benefit of a gambling treatment pathway will contribute to many areas, including health inequalities, working with the voluntary sector and primary care networks, as well as provider collaboratives. NHS treatment should be part of a wider population health approach. And what we know from the work that we do in the clinics and from the evidence base and the literature over the years is that gamblers come with other difficulties and other needs as well. So not only can those partners help in identifying problems, but they can also work within an integrated care model and with the clinics to provide the wider needs that these service users need. And often these other needs can be a real threat to sustained recovery. So it's really important, it's self-defeating for us in the clinics and in the NHS to be working on the gambling problems and discharge them. For many, they will need other needs met, and if they're not met alongside us, then that will be could present as a direct threat to their recovery. Next slide, please. So we talked about gambling harm lying on a continuum of severity, and this is one depiction of a reflection of that, and where we might have, you know, recreational gambling at one end and people becoming at risk and experiencing low to moderate levels of harm, all the way up to the sharper end that the NHS are involved in, where you get common comorbidities as well as gambling disorder, but also a system which includes approaches which are going to facilitate sustained recovery. So that it's not uncommon for people to have relapses, which can be devastating. They can be a suicide risk. So I think the NHS also needs to sit within an ecosystem of support which connects those people who need it to sustained recovery interventions. And I think it's likely that the charitable sector are going to perhaps play the most significant role there, and perhaps at the low to moderate harm level as well. So I think accurate identification and screening should lead to the most effective intervention, from providing information to brief interventions, to the work of the charitable sector, the mobilizing the work of peer support, which has been really underplayed in this space, and they've got a great contribution to make. The specialist clinics dealing with gambling disorder and comorbidity. And we've obviously got rehab as well to think about for those service users that need a different kind of intervention. And as I say, a system that connects to sustained recovery and relapse prevention initiatives that really build individuals' recovery capital and helps them to reconnect with a life worth living. Next slide, please. So as I said at the outset, it's not a homogeneous population, and there's research of over 50 years duration looking at sort of subtyping the treatment population. And there are three pathways broadly that literature has focused on, and I've added a fourth here, which I'll explain in a second. So the top three there are broadly the three groups of service users that we see in the clinics. Categories are never perfect, and sitting behind these pathways obviously are real lives and a variety of different needs. So I'll just mention these briefly. The first one, known as the behaviourally conditioned group, generally these are individuals who don't report background or developmental difficulties, would talk to me and say, you know, I don't know how I've ended up like this. I had a good upbringing, good parents, popular at school, etc., etc. No mental health problems, and their presentation is all explained by gambling and the devastation that gambling can cause. So yes, this group are distressed. They'll present with anxiety problems, depression, suicidal ideation, if not suicidal acts, and so on. So it's still a very serious group. It's just that the traditional comorbidities don't come with that group. So yes, to the layperson, they might look like they've got lots of comorbidities, but they're all explained by gambling disorder and the consequences of living with a gambling disorder over a prolonged period of time. And it's really effective to treat that group with the gold standard evidence-based treatment, which is CBT. That does, usually does a really good job with that group if done well. The second group, which is our most common group certainly in the northern clinics, we have about 35% in the top group. Probably say about 50% of the second group, if not more. So this group have been termed the emotionally vulnerable group. So they'll generally describe much more developmental disturbance and difficulties from childhood, perhaps with caregiving and relationships growing up, difficulties managing emotions, perhaps with low mood, anxiety. There might be some trauma in the background, and they come to the gambling experience and gambling space where they're really reinforced by gambling activities, because it helps focus their minds, it takes them away from their problems, helps them to escape, helps them to focus their attention in an immersive environment for prolonged periods of time, and they can feel, to them, in control and normal and able to function. So this group, and obviously the NICE guidelines are going to assist us with all of these pathways. The CBT plays an important role here, but it's, in our experience, they need a little bit more, particularly around their distress and helping them with their experience of emotions. Often there's more than one behavior. It's not just gambling. There might be alcohol, there might be drugs, there might be eating difficulties, other ways in which they self-regulate. So other approaches are really important as well with this group. And obviously we'll be thinking about the extent to which the clinics do this versus bringing in other support from the wider health system. The third group is an impulsive group. So people who are highly impulsive, ADHD will sit in here as well. So again, this group don't always benefit from going straight into CBT. They may need support with impulse control in addition to CBT. We're piloting an ADHD specialist pathway within our clinics. It can take a couple of years to get treatment for ADHD on the NHS. And this group are really disadvantaged. They come to us desperate and in desperate straits with their gambling problems. And to tell them, well, you're going to have to wait for 2 years before you have your ADHD, before that stabilizes and settles down your symptoms in order to benefit from our talking therapy, feels to me a disservice to the population. So we're piloting the ADHD pathway in the northern clinics, as well as looking at impulse control interventions in addition to the CBT. Finally, what we've increasingly seen, and I know it's the same for Etta and Becky's clinics, we're seeing more complexity in presentations and people who are not likely to benefit from the talking therapy pathways, or at least not initially. So these definitely need a wider system of care, and we may play a modest role in that. Often it's really for the CMHTs to take the lead on this patient group, and we may just consult to the CMHT with brief interventions and interventions around stimulus control and so on. Or we may have, it's not one group, so we may be able to help them a little bit more in the clinics as well, and help some of them move through our pathways once we've stabilised them and worked on the assessment of risk and stabilising some of the mental health symptoms. So in broad terms, this is the clinical population that we're seeing. It's a diverse population, and it's important that we assess their differing needs, and going forward, we'd like the clinics to offer, highly specialist treatments to address many of these needs. Not all will need partners and colleagues and other services, but as far as possible, under one roof, they can get the specialist care that we need. And it's worth mentioning again the family pathway as well. So we've got a pathway for affected others, which obviously Jim's going to talk a little bit more about, so I won't steal his thunder about the intervention that I know he particularly supports. But we have family therapy as well, to support that, to support the family system as well where that's needed. So yeah, that was just to underscore, really, I suppose, a bit more meat on the actual the nature of the population, the diversity in it, the specialist treatment that's needed at the sharper end, some of the comorbidities that we're having to work with as well, and just the need for a proper evidence-based system of care from early identification all the way through to aftercare with the support of the voluntary sector and peer support.